Okay, everybody, it's 4 o'clock. I guess we should start this ERKNet ESPN webinar on renal hypophosphatemia. I would like to welcome you all. My name is Tom Nijhuis. I'm a nephrologist at the Radboud University Medical Center in Nijmegen. I will be your moderator today, and before I introduce our speaker, I would like to ask you to take notice of the question box in the GoToWebinar panel. So if you have any questions during or after the talk, please put them in the questions box so I can ask them to Dieter. And with that, I come to Dieter. So I'm very happy to introduce Dieter Haffner today. Dieter is a professor of pediatrics, head of the Department of Pediatric Kidney, Liver and Metabolic Diseases, coordinator of the Center for Congenital Kidney Diseases at the Center for Rare Diseases at Hannover Medical School. And his main interests are in the genetic and mechanistic exploration of rare kidney diseases and mineral and bone disorders in children with chronic kidney disease. And as such, he has been heavily involved in different roles in the ESPN, in IPNA, as well as, of course, in ERKNet. And today, Dieter will give a lecture on renal hypophosphatemia with a specific focus on children. Well, Dieter, the floor is yours.
Thank you very much, Tom, for this nice introduction and for the invitation to give this talk. I will focus today on renal hypophosphatemia in children because I'm a pediatrician. So first my conflict of interest, and then I move on. So if the patient shows up in your clinic, it's not signed to be a patient with renal hypophosphatemia, but he has some clinical presentation, and the clinical presentation is always rickets, because hypophosphatemia results in a mineralization defect in the chondrocytes, and this we call pediatricians rickets. But there are other forms of rickets, and I will guide you through an algorithm we always follow during the talk to look for differential diagnosis to render the correct diagnosis. So what's rickets in clinical presentation? So we have patients present with leg deformities, a wetling gait, muscle weakness, short stature, and widened wrist. On radiography, they show the typical features like metaphyseal fraying, widening of growth plates, and leg bowing. And it together with the clinical presentation and radiography, there's obligatory the biochemical hallmark, which is an elevated alkaline phosphatase. This together, this symptomatology qualifies the patients to suffer from rickets. By looking at the patient and at the alkaline phosphatate levels and the radiology findings, it's usually not possible to render the correct cause of rickets. So it always needs a biochemical and often also a genetic workup. And the starting point of everything is the differentiation between the so-called phosphopenic rickets, that's hypophosphatemic rickets, and there's also our group of renal hypophosphatemia within this group, and then the called calcipenic rickets, where we have a primary disturbance in the calcium and vitamin D metabolism. If so, these patients present with markedly elevated PTH levels. So if a patient shows up with rickets and markedly elevated PTH, it is never renal hypophosphatemia, it's always some of those diseases, and which are just summarized here. Of course, the most important thing is vitamin D deficiency. The patients have very low levels of vitamin D. And then we have the so-called vitamin D dependent rickets. And all these formed together have sky-high alkaline phosphatase and sky-high PTH. They also have renal phosphate wasting because of PTH. PTH is a phosphatic hormone. So if you just look at TMP over GFR, you cannot discriminate this. In addition, many of those patients have a tendency for low calcium. However, it depends always how long the disease has started. And then you have to do a biochemical workup and then also the genetic workup. Sometimes it's easy, like in patients with vitamin D dependent rickets type 2-1, they may show up with alopecia, so it's a quite easy go for diagnosis. So coming back to the other forms, so we excluded those forms with high PTH. We're coming to those forms where we have either low phosphate due to low phosphate intake. This is a nice pitfall to appreciate always. So if you have low levels of phosphate in urine, so then the low serum phosphate levels are not due to a phosphate leakage in the kidneys, but they're rather due to low phosphate intake. And those patients may have short bowel, or you may have an enhanced extrarenal removal of phosphate from the body, for example, phosphate binders and something like that. So this has also to be excluded. If there's a lot of phosphate around in urine and you excluded high PTH, then we have all nice forms of renal hypophosphatemia, which could be just due that the kidney has a problem. Let's say you have a hereditary disease where the phosphate transporters are defect, like the hereditary hypophosphatemic rickets with hypocalciuria. There's an RP2C transporter defect, or you have inherited acquired forms of Fanconi syndrome. The most common cause is cystinosis, but you may also have a patient who has maybe chemotherapy or other drugs which compromise the function of the proximal tubule. And those patients often have hypercalciuria, and then they have, of course, glucosuria or aminoaciduria. And then you have the forms which are driven by another phosphaturic hormone, not by PTH, but by a fibroblast growth factor 23. And this is a large group of various diseases. I will show you later on through this different kinds of diseases. And the most common cause of these inherited disorders is X-linked hypophosphatemia. And for this disease, there's the best evidence we have, and we just performed 1 year ago a guideline project together with adult nephrologists and endocrinologists, and I will guide you a little bit through this guideline, and I will primarily focus on XLH now, but we'll always tell something about the differential diagnosis and the pitfalls. So XLH is the most common cause of inherited phosphate wasting. It's characterized by renal phosphate wasting and resulting in hypophosphatemia and reduction 125 synthesis. Key characteristic, like in other kinds of rickets, is this rickets, disproportionate short stature, and osteomalacia, and odontomalacia, because the gene is also expressed in the teeth. And patients usually present with first symptoms within the first 2 years of life, but diagnosis may be delayed due to the diversity of clinical manifestations and the rarity of disease. So we have mutations or pathologic variants in the PEX genes. It's not clear what the function of the PEX gene is, but we know that the loss of function of this gene results in elevated synthesis of FGF23 in the osteocytes. And this causes two things. FGF23 reduces the abundance of the NAPID transporter in the kidney, so you have a phosphate leakage resulting in low serum phosphate, and FGF23 suppresses the renal synthesis of active vitamin D, calcitriol, by suppressing the 1-alpha synthetase. So you have low serum levels, or let's say inadequate normal or low serum levels of 125, which results in reduced phosphate reabsorption. So the combination of low phosphate via NAPID suppression and low 125 results in rickets. And then the patient has, of course, also high alkaline phosphatase. So I think it's time for the poll question number 1. So the question is, it's just informative. I would like to know from you, how many patients with XLH have you seen so far? It's none, 1 to 4, 5 to 9, 10 to 15, or more than 15. You see the known numbers because it's really a rare disease. Okay, half of the colleagues have seen non-patient, and some have seen 5 to 9. So it's really a rare disease, and that's why we are going today for this guideline overview. Okay, so I'll try to move forward. Here we are. So we come to the guideline project, and you will always see the grading of the guidelines coming from strong, where there's a high evidence, and if the benefit or harm predominates, and in most circumstances we have moderate evidence, and then very often we also have weak recommendations, and because we have only a few observation studies, or we have inconsistent findings, and then it's a weak. When we use the word we recommend, then it's usually moderate or strong recommendation. If we use the word we suggest, then it's a weak recommendation. Okay, so when to consider the diagnosis of XLH? It should be considered in the presence of clinical and radiological signs of rickets, impaired growth velocity, and serum phosphate levels below age-related reference range associated with renal phosphate wasting in the absence of vitamin D or calcium deficiency. So here we exclude the calcipenic rickets. So it's based on the clinical, radiological, and biochemical assessment. With the clinical assessment, we look for evidence of rickets or growth failure, dental abnormalities, because the PEX gene is also expressed in the teeth. So they have mineralization defects or later on abscess in the teeth. Patients may have signs of granulosynostosis or intracranial hypertension, and we of course need an orthopedic assessment. Okay, and then we move on to the radiological workup. So it's recommended to make a thorough radiological workup. The best would be to make a full screening of the lower legs to diagnose and grade rickets and to look for osteomyelitic lesions. And then we come to the biochemical part. And this is not difficult because you need just a few parameters. You need, of course, serum levels of phosphate, calcium, alkaline phosphatate, PTH, and then 25 vitamin D and 125 vitamin D, and then of course creatinine to rule out rickets due to severe chronic kidney disease in young children, which may present also with severe rickets. And then very important, very cheap, but very important, the urinary calcium and phosphate and creatinine in the spot urine, where we should calculate the renal phosphate threshold concentration, TMP over GFR, to prove renal phosphate wasting and to prove that urinary calcium creatinine ratio is normal. Because if it's not normal, this may point to Fanconi syndrome or hypophosphatemic rickets with hypercalciuria, which are very important differential diagnoses. And then, as having said before, you have to check for non-selective renal tubular phosphate wasting by checking the serum bicarbonate, amino acid, glucose, or uric acid losses in urine, and low molecular weight proteinuria, just to exclude Fanconi syndrome. So what is the typical features? So we have low serum phosphate, moderately elevated alkaline phosphatase level, reduced TMP over GFR, serum calcium is usually in the lower normal range. Urinary calcium is usually rather low because FGF23 decreases 125 synthesis and thereby intestinal calcium absorption. PTH is usually normal or maybe slightly elevated. But please don't get mixed up that this may be calcipenic rickets, because in calcipenic rickets, PTH levels are markedly elevated. So if PTH is elevated just a little bit above the upper normal range, don't bother. This is compatible with the diagnosis of XLH. And 125, they are usually normal or inappropriate normal in the setting of hypophosphatemia. If it's elevated, then it also points for hypophosphatemic rickets with hypercalciuria. And then in patients who are untreated, this is very important because if you give vitamin D or phosphate, you stimulate FGF23, patients have usually elevated FGF23 levels. So the age-dependent normal range of serum phosphate levels really matters. You have to look at, and unfortunately, many children who are screened because of a positive family history may present with phosphate levels in a low normal range. So this is not always conclusive to render the diagnosis, but of course, if you want to consider the diagnosis, you have to check the reference values. And then with respect to renal phosphate wasting, in adult patients, usually the nomogram von Walton and Biové is used. This is not validated in children and has some errors if you use it in children. So in pediatrics, we usually use the Prodel formula or other formula where you use just the spot urine, where if you have serum phosphate, urine creatinine ratio, and serum creatinine. And you can calculate this by yourself, or you may use an online calculator. And I mentioned here the online calculator of the German Society of Pediatric Nephrology. It's in English, so you may use it, and it's also indicated the reference values for that. So if you have all these biochemical features, it's recommended to confirm the diagnosis of XLH by genetic analysis. Why? There are maybe other disease you cannot discriminate. I will show you later on the differential diagnosis. And on the other hand, there's now a new drug available, which is only licensed for the use in children with XLH. It's burzumab, is an FGF23 antibody. So if there's a negative test result with the PEX gene mutation, then you have to consider other causes of hypophosphatemia and renal. Usually you do this by next generation sequencing, by checking for panel for other possible diseases. If you have not genetic analysis available, and you may perform checking of FGF23 levels, so in case if they're ever elevated, or if there's a positive family history for XLH, you may support the diagnosis of XLH. It's usually elevated, FGF23, but it's markedly influenced by other factors, for example, by anemia, or also by phosphate intake and vitamin D therapy. So if a patient is already on treatment, you cannot trust FGF23 levels. You may have to stop it for at least 2 weeks. So there are age-dependent normal levels, which are a little bit higher in young children. And so far, there's no clear cut off when to diagnose a patient with XLH. And the most reliable studies in Japanese children, there was a cut-off levels using the Kinose assay proposed with 30 picogram per ml. So now we are coming to the differential diagnosis. So if you look at other diseases causing FGF23 driven renal hypophosphatemia, we have to go through many diseases, and these are just summarized here. To start with, just looking at biochemical parameters, they all look the same. So you always have phosphate wasting, low TMP over GFR. You may have normal or elevated FGF23 levels, and vitamin D levels are usually not helpful at all, and alkaline phosphatase levels are mildly elevated. So if you really want to know this, you need a panel sequencing to do that. Sometimes it's a rare cause, but it's quite nice to diagnose. If you have a patient who presents with a rather high age at presentation, maybe in adolescence, then it's maybe autosomal dominant hypophosphatemic rickets, where the degradation of the FGF23 protein is altered. And then another pitfall, which is rare, but it's very important. So if you have a high FGF23, typical renal hypophosphatemia, and even no negative genetic panel testing, then you should always seek for tumor-induced osteomalacia, which is quite tricky. They are usually small mesenchymal tumors. You need whole body scans with MRI or PET scan or other technology. But it's worth to go because you need to render the correct diagnosis. And then there are, of course, other rare syndromic disease. We may have a classical feature, like for the Rain syndrome, and we always check this with a panel, genetic panel. So having said this, the mode of inheritance, so if you have a family, a positive family, or you want to know if it's probably XLH, so if the father is affected, then all boys will be unaffected, but all girls or all daughters will be affected. On the other hand, if the mother is affected, then half of the boys and half of the girls are affected. XLH is caused by mutations in the PEX gene. It's a large gene with 22 exons. Unfortunately, there's no hotspots. So if you want to check, you need to sequence the whole gene. And PEX gene mutations may be are found in 87% of familial cases and 72% of sporadic cases. There's no clear genotype-phenotype correlation, but there's a trend toward a more severe skeletal disease in patients with truncating mutations. So how to monitor? So we have to check anthropometry, we have to check annual height velocity, we maybe have to perform radiographic investigations of the wrist and or knees, especially in those patients who do not respond to well to therapy, who worsen their bone deformity under medical treatment or require orthopedic surgery. You have always to check for rare complications like hearing loss, motor spine deformities and scoliosis, GRE1 malformation, and you have to check also for dental abscesses, which is very important. So patients have to regularly show up at the dentists. And here are just some pictures on the rare but important complications like granulosynostosis, which is a typical head shape, GRE1 malformation. Patients may have signs of intracranial hypertension with headache and vomiting, syringomyelia. Patients usually have impaired muscle function, which is improving during treatment. And unfortunately, due to the skeletal complications, there's usually reduced mobility, and especially in adults, there's a problem or the challenge of weight gain. And very rarely in children, but rather more common in adults, there's a hearing loss and a tendency to get tinnitus or vertigo. So how to monitor? Monitoring is just easy. You just need alkaline phosphatase. In adults, you go for bone-specific alkaline phosphatase. You have to check calcium phosphate, creatinine, PTH1 and 125 levels. And you always should calculate the urinary calcium creatinine ratios to rule out hypercalciuria, which is especially a problem during conventional treatment. In patients who get the antibody against FGF23, which blocks the activity of FGF23 in the blood and thereby ameliorates or completely clears the renal phosphate leakage. You also have to check the serum phosphate level, which are supposed to increase, together with TMP or GFR, to check how the improvement of the renal phosphate handling improves. And this has to be done every 2 weeks during the first month, every 4 weeks for the following 2 months, and thereafter as appropriate. And it's also expected or recommended to measure 125 levels because it's a low risk, but it may happen that if you give the FGF23 antibody, then you have an exaggerated 125 synthesis. So it's recommended to at least 6 monthly or 12 monthly check 125 levels under burosumab. So what about the treatment? I would just start what the guideline tells from 2019. So at this stage, we recommend that children with overt XLH phenotype be treated with a combination of oral phosphate and active vitamin D as soon as diagnosis is established. So the starting dose for phosphate is 20 to 60 milligram per kilogram per day based on elemental phosphorus. That's very important. So you may also calculate just the millimole. Please remember, you give the patient phosphate salts, but the dosage is based on milligram elemental phosphorus. So there's a lot of misunderstanding on this figure. Please always check the content of elemental phosphorus. And the dosage is adjusted to improve rickets, growth, to normalize alkaline phosphatase, and to keep PTH levels in the normal range. That's why you always combine the treatment with phosphate together with active vitamin D. It's not a goal to normalize serum phosphate levels because the renal phosphate leakage is still present. So we always check this, but we don't guide the treatment, the conventional treatment with measuring or by measurement the serum phosphate levels. Young patients with high alkaline phosphatase level need frequent administration of phosphorus 4 to 6 times per day, which may be lowered to 3 or 4 times per day when alkaline phosphatase has normalized. And you may increase the dosage up to 80 milligram per day, but you need to take care to prevent gastrointestinal discomfort and hypothyroidism. And it's of course mandatory to use lower dose in milder phenotypes, especially in young infants just diagnosed by family screening. So you combine it with active vitamin D. Why? Because you have a deficiency of 125, so it's good to give this active vitamin D. On the other hand, vitamin D also increases the phosphate reabsorption in the gut. And in a third, a very important factor is that calcitriol ameliorates or blocks the elevation of PTH, which is usually driven by phosphorus medication if you give it phosphorus alone. So the initial dose is for calcitriol, it's about 20 nanogram per kilogram, and as a rule of thumb, you need the double dose if you give alpha calcitriol. This is due to the decreased intestinal availability of this drug. And empirically in infants, you may start with 0.5 calcitriol. You always have to check the levels of native vitamin D, 25 vitamin D levels, which may be sometimes low, like in other children, and you should support it, supplement this according to national guidelines, like for other children with vitamin D deficiency. So now there's a second poll question. Could you start the second poll question? It's here. So Michael, I would like to know if burosumab is available for treatment of XLH at your center or at your institution. So you may say no, yes, but only under certain conditions. For example, biochemical conditions, proven XLH genetic diagnosis. And if it's available, is it available for all children? Is it available for all adults? Or is it available for all patients? That means children and adults. So please give an answer. Okay, so in most centers it's not available. So that's good why we talked a lot about conventional treatment. Okay, thank you. It's very interesting. And I move on. Okay, so when to start with burosumab? This guideline was finished in 2019. At this stage, there were just preliminary study results with burosumab treatment. So at this stage, we didn't know if burosumab is superior to conventional treatment. We didn't know so much about side effects. So we thoroughly discussed in the guideline committee, looking at the clinical studies, which patients may be preferably treated with burosumab, which patients deserve it most. So there's no data on the use of burosumab in children aged less than 1 year. So we said, if available, we recommend considering burosumab treatment in children aged 1 year or older and in adolescents with growing skeletons, if they have radiographic evidence of overt bone disease, so there must be something going on, disease, and if they are refractory to conventional treatment, or if they experience complications related to conventional therapy, which could be nephrocalcinosis, hypercalciuria, or maybe persistent secondary hypothyroidism, or that's especially important in adolescents if they are unable to adhere to conventional therapy. However, if they are adolescents with reduced adherence to drugs, it must be presumed that the adequate monitoring is feasible. So that's the how we recommend it in 2019. And the starting dose at this time was 0.4 milligram per kilogram in children, given every 2 weeks subcutaneously. But meanwhile, the EMA adjusted the starting dose to 0.8 milligram per kilogram, because in the clinical trials, most patients required at least 0.8 milligram per kilogram. However, we know from our registry we perform in Germany that some patients quite do well with 0.4 milligram per kilogram. Anyway, patients, the dosage should be titrated in increments of 0.4 milligram per kilogram to raise fasting serum phosphate levels to within the lower end of the normal reference range for age. And the absolute maximum is 2 milligram per kilogram, or the absolute dose 90 milligram. And burosumab should not be adjusted more frequently than every 4 weeks. Indeed, if you look at pharmacokinetics and you use the same dosage, you need up to 3 months to render a steady state. So if you titrate the dosage, you need to wait at least 4 weeks and then consider to increment the dosage. So please be rather reluctant, don't be proactive, and don't change the dosage too often. This also may provide concerns in the family, and this is not helpful at all. So it's recommended to monitoring the fasting serum phosphate levels between injections. And then we thought, well, there's a pharmacokinetic, so the peak of burosumab in the blood and also the effects in the kidney with respect to holding back phosphate is between 7 and 11 days. So in the start, you may want to detect hypophosphatemia. So it's a safety parameter. So we say, well, if you measure it between 7 and 11 days after injection, it's very good to detect hypophosphatemia. If you have a steady state, which is usually assumed after 3 months, you have a stable dosage, and then you want to detect hypophosphatemia, you want to exclude, and then it's recommended to do this maybe directly before the next injection. So that's not mandatory, but if you want to exclude hypophosphatemia, you always have to check when the drug was given. And many people and many patients and doctors get confused because the serum levels are rather changing, but it's just due to the different time intervals between giving the drug and measuring serum phosphate. So if phosphate levels are even increased above a normal range, you should withhold the dosage and maybe restart it with half of the dosage if the phosphate levels are below the normal range again. And conventional treatment is not allowed to combine with, so you must stop active vitamin D and calcitriol before you start this medication. So meanwhile, there's a head-to-head study where the treatment of children aged between 2 and 12 years at start was compared between children just receiving conventional treatment and those with burzumab. And as you can see, the serum phosphate levels were quickly raised up in the lower normal range by burzumab. Please notice, if you look at week 40, that the mean phosphate levels was just a little bit above 3.2 milligram per deciliter, which is the lower normal range. That means in this trial, about 40% of the children had a phosphate level below the lower normal range. So, and I'll show you in a second the X-rays and the alkaline phosphatase level. So this means that the results I will show you now are occurring, although some patients are not in the lower normal range. Of course, phosphate is increased, but it's not normalized. And in this population, you can see that the alkaline phosphatate levels really drop down dramatically in the burzumab treated patients. They usually normalize within 40 weeks, which is wonderful. They slightly decrease in the control group, and that what even more matters is the bone. So we treat bone. We don't want to treat phosphate. We just guide a little bit treatment by phosphate, checking phosphate levels. They checked the rickets severity score according to Thatcher, which is a combination of the signs of rickets, which are just shown here. And usually the patients had to have a score of at least 2, which is really a moderate or severe ongoing hypophosphatemic rickets, despite active vitamin D and phosphate treatment. And having said this, you can see here after 40 weeks that in the patients on burzumab, they have a marked improvement of rickets, whereas in the patients on conventional treatment, there was a little bit improvement, so maybe more better adherence. But in patients on burzumab, the mean rickets severity score was 1. That means there were only mild signs of rickets. So it was very effective. And having said this, burzumab was superior with respect to improvement of rickets and healing of rickets compared to conventional treatment. That's why we have to update a little bit our guideline. This will be done in next month. And currently, the current approach in most European centers is that the first-line treatment of children aged above 12 months is either with burzumab or phosphate and vitamin D, depending on its availability. So just on a case report, I just want to show you how tricky it is sometimes to treat a patient. So this patient was a female, a girl. The father suffers from XLH, so we made the diagnosis at the age of 0.1 years. We started with conventional treatment, and as you can see here, the phosphate levels were still in the lower normal range, but we knew it from the genetics that there's a disease, and elevated alkaline phosphatase started to elevate at 0.2 month, and then we started with conventional treatment, and I was quite happy with the treatment because PTH was in the normal range, and alkaline phosphatase level were in the upper normal range. But I was extremely happy at the age of 1 year with the biochemical findings. However, biochemical findings are fine, but what matters is really the clinical findings. And I have to confess that despite this treatment and a constant increase in phosphate and 1-alpha medication, there were decreasing quality of bone. And you can see here that there were severe tibia deformities and pain, and this even progressed during treatment. And in addition, there was poor growth. So the patient had a height just below the 3rd percentile. That's why we switched him to burzumab, which is licensed after 1 year age. This was an easy go. We started with 0.4 milligram per kilogram. We increased this dosage gradually to 1 milligram per kilogram. And as you can see here, phosphate levels were quickly normalized. Alkaline phosphate levels were suppressed. They were really in the middle of the normal range. TMP over GFR was normalized. I was really happy. And you see that the bone bowing really improved. So the child is now really a rapid walker. she's really rather more fast than I am if I have to chase her in the outpatient setting. And unfortunately, the growth was not improved. And at this time, the clinical studies just came out with the small children with XLH treated with burzimab, and this poor growth outcome was just, I have to confess, typical, because in the clinical studies the mean height was not significantly increased in those children, but the authors from this paper highlighted that in most children on conventional treatment, these are the small dots here on the graphics, usually have a progressive growth failure. So they say, well, even there's no improvement in standardized height, at least they are constant, and this must be highlighted as a rather good response. If you look at the improvement of standardized height in the older children, aged between 5 and 12 years of age, there's a slight, but really significant, but very only a slight improvement of standardized height. So having said this, the drug is wonderful with respect to improvement of rickets, but it's not a rocket with respect to improvement of growth. So to complete, especially the part on XLH, the correct diagnosis matters. The symptomatic treatment has its pitfalls and its challenges, and burzimab was shown to be more effective than conventional treatment with respect to healing of rickets and physical functioning. However, we don't know about the long-term effects with respect to growth. We don't know if the teeth problem improves quality of life, and endotheliopathy, which is a problem, which is calcification of the tendons, especially in adults. We don't know the effect yet of burzimab. So it's important to collect the natural history of disease and to perform prophylactic registry. And there's currently a trial going on with burzimab in infants to check if early treatment may improve the outcome. Having said this, I would like to thank you for your attention. I'm happy to take your question. Thank you. And then the next webinar, sorry, I had to forget, the next webinar will be on the 21st of September by Ort Surveyor. It's about cystinosis adult view. Thank you.
Okay, thank you, Dieter, for the interesting presentation. I don't see that much questions yet in our question box, so I would like to urge everybody who wants to ask a question that this is the moment that you can ask the expert the question. I have at least learned today that as an adult nephrologist, I can be happy that I don't need to chase my patients through the outpatient clinic, which is nice. I was wondering whether you could say a little bit about, because you started with the diagnostic algorithm, and you said there, let's say when the phosphate is low, you come into a certain differential diagnosis when the phosphate in the urine is high to another one. But what is actually high and especially what is low? Can you say something about that?
Yeah, there are published normal ranges of the urine phosphate levels, and in children with a phosphate creatinine ratio, and they are nicely published. So, but usually, you know, if it's below, if you don't do the ratio, and if it's 1 millimole per liter or 3 millimole per liter, that's low. If it's 10 or 15, then it's rather high. Yeah. So there's no.
Yeah.
So there's no exact cut off, and if you want to measure it more exactly, you go for the phosphate creatinine ratio. It's, you know, it just want to highlight that it, you know, it's very rarely that you have low phosphate reabsorption from the gut, but if you calculate the TMP over GFR and you look at the formula, you always subtract the ratio from urine and serum with phosphate from the serum phosphate level. So if you have no phosphate intake, by definition you have low phosphate level, and then the formula doesn't help you to indicate to render the diagnosis of low phosphate reabsorption. So it's worth to look at the phosphate, just at the phosphate in the urine, to see if there's just almost nothing phosphate in urine, you may want to consider that there may be no phosphate reabsorption from the gut or reduced. It's just a pitfall very rarely, and I just want to highlight this by this.
So, and I think important is that one of the important points I took from your presentation that the goal is actually to normalize alkaline phosphatase, right, in the treatment of XLH.
That's right.
I think that is something
together with the clinic, so growth, better bowing of the legs, and then alkaline phosphatase if it's in the normal range or maybe only slightly elevated during conventional treatment, we are always happy.
Yeah, but it's not so much, let's say, the goal to normalize serum phosphate, I guess, right?
On conventional treatment, by definition, you never normalize it, but because the phosphate leak is still present. So if you look at the blood, if you give phosphate orally 6 times per day, you always have 2 hours of higher phosphate levels, and then it goes down again. And these small peaks are enough to improve the bone. But if you have just a fasting phosphate, it will never be changed because the leakage is still there. That's why it's rather ineffective just to give the conventional treatment. However, it was the only medication we had until 2 years ago.
And if I take you a little bit to the adult situation, of course, you talked about pediatrics in this presentation. But it always gets a little bit difficult when these children grow up to be adults, because then the question is, should you go on with, let's first talk about conventional treatment, right? Should we go on with conventional treatment because they are not growing anymore, their skeleton has become adult, and then the idea is how critical should you be on the calcium excretion then, or should you actually let's say reduce or even stop the conventional treatment, because otherwise you might run into side effects of the conventional treatment.
So most adult physicians stop a medication if the growth is over in the patients, if the patients start to have bone pain, signs of osteomalacia, maybe pseudofractures, or ongoing teeth problems, then it's recommended to restart phosphate and active vitamin D, but at rather low dosages. But it's
sometimes these patients develop rather low serum phosphate levels, like 0.3 millimoles per liter, and then I get a little bit worried.
Yeah, I understand. So and it's always the discussion to start with. So I don't know if growth is over and the patient doesn't have bone pain and things like that, then I would maybe not just render the decision to start by looking at the phosphate. I think it's always tricky for us physicians. If we have numbers, then it's more impressive for us if we have the clinical presentation. So, but I learned from the adult endocrinologists and nephrologists that they usually look at the clinical symptomatic.
Yeah, sure,
but I know there's no evidence. You may start this. There's nothing wrong with that, but the evidence, there's little evidence. So now burosumab is also licensed in adults. So if patients have osteomalacia and bone pain and things like that, they may be started on burosumab, and we know that the osteomalacia markedly improves, and those patients who have pseudofractures, they usually are completely healed by burosumab. But then is always the question: do you have to give this lifelong? It's a very expensive drug, so it's still not clear. And I'm happy that I'm a pediatric nephrologist, so we just treat. And it's mandatory in many patients to treat burosumab, but in adults, I don't know what is the right thing to do.
And yeah, I guess, let's say in the Netherlands, I think it is the case that you can prescribe it to adults, but only for 18 months. So that means that if they have a fracture or you can treat them for 18 months, but not lifelong yet. Yeah.
I think that's, you know, we're all learning now, and I think the health authorities always have to look at the evidence for all those drugs, and I think it's good to not to give every patient this new drug, but to really think about who really deserves it.
I have a question in the question box, and I guess that this question is related to the discussion we just had about what is low with respect to phosphate in the urine. And this question is it preferable to do a 24-hour urine collection to check for phosphate wasting?
Usually it's not helpful because if you have just phosphate spot urine and you do check the phosphate creatinine ratio, it's more or less the same helpful. When I did my training in pediatric nephrology some decades ago, my former professor always told me, just ask them to bring 24-hour urine and check the urine phosphate, just to check if there's a lot of phosphate during conventional treatment, then you are sure that they are taking their phosphate. But you know, I think it's not superior to have a 24-hour urine, and in the outpatient setting, it's much more easy to do a spot urine sample every time they show up in the clinic.
Of course, yeah. And maybe that's also more a problem of our or of us adult nephrologists, but we tend to run into people who have a low phosphate, and then the phosphate was actually determined because they had non-specific symptoms. And then we do a thorough checkup. We do the complete analysis, and in the end, we don't find. We find urine and phosphate wasting, but we don't find a cause. And then the question always is what to do then, because should we treat these patients? Are we overlooking a cause somewhere that we can't find?
That's right. And then you have the problem that the tumor-induced osmolasia may happen more frequent in adults. So if available, so if you have no signs of Fanconi syndrome going on and no drugs exposure or so, you may, if available, a gene panel would be nice to have. And if the gene panel is negative and you have clear renal phosphate wasting, and then you may check FGF23 levels. If they are elevated and the gene panel is negative, then you have unfortunately to go for the tricky way to check for tumor-induced osmolasia with all the scans. Mm-hmm. This is not nice, but at least I would think about that. Sometimes the patients with tumor-induced osmolasia, I have never seen that because they are usually adult patients, they have very, very severe symptoms, and they sometimes have a lot of bone pain. So they usually come with bone pain.
Yeah, that's usually a little bit how we do that. So we look at the phenotype, and if people have a lot of complaints, especially if they have bone complaints, then we go on to look for the tumor-induced osmolasia. Yeah.
That sounds very good, because if they have no complaints, you know, it's time-consuming, it's costing, and it's inconvenient for the patients to do all the scans with X-ray exposure, and so yeah, it sounds good to me.
I have another question from our question box here, which is there a role for bisphosphonate treatment in children with renal hypophosphatemia and recurrent fractures?
A clear no. There's no evidence, and I would never give it to a patient for that, because it's a different pathophysiology. You have a mineralization defect because of low phosphate. It's not helpful. Yeah. It was never checked.
Clear answer. I think with that question, we have come to the end of the questions, at least in our question box. Well, thank you again, Dieter, for presenting the interesting seminar. Would like to thank everybody attending and everybody involved in posting questions. And I would like again to draw your attention to the next webinar, which is on the 21st of September, as Dieter said, on cystinosis. Well, I wish you all a good day and see you at the next webinar.
Bye-bye. Thank
Bye-bye.
you. Bye-bye.